how do I know this is not just acidity or I'm having a heart attack?
It's a very important, very pertinent question. Acidity is typically something that happens, but somebody who's never had acidity before, is a male gender, who's above 40, 45 years of age, and suddenly out of nowhere tells you, I'm getting burning or acidity, beware. Number two, when I walk, I get burning or acidity.
Yeah.
But if I sit down, it gets better. That is pain from heart, not acidity.
Is there evidence now that microplastics from single-use plastic bottles and things like that are making our hearts weaker?
Yes, microplastics can not only cause cancers, but they can make our heart weaker. Cardiovascular disease, CVD, is the number one killer across the world. 85% of these deaths are preventable. I wouldn't say there is any correlation between work, how many hours you walked versus a heart attack. But there is correlation between lack of physical activity
Yes.
and heart attacks, lack of socializing and heart attacks,
Okay.
and
Sleep.
lack of sleep and heart attacks. There is recent Harvard study. They compared people who lived 70 years, 80 years, 90 years, and they went back 30, 40 years. They found out that those who lived alone, lived and versus those who lived with families or with friends. So those who socialized more lived longer compared to those who did not socialize.
Why do we still have an efficiency of doctors in India? Why, are we not able to meet those numbers yet?
Honestly, there are two things. One are population. Numbers very big.
Yes.
Two, it's a relative deficiency also. Like there are parts of urban India where there are doctors which are more than required, and the part of rural or suburban India where there are doctors which are not there only.
Do you expect going forward that India's health needs will be met by the private sector or by improved services in the public sector?
Medical insurance for everybody would do the trick.
So in an attempt to talk more about our health, our mental health and our physical health, we've been doing a series of conversations with very established and respected experts in the field. Today, Dr. Maulik Parekh joins me. He is the head of TAVR and he heads the Structural Heart Program at the HN Reliance Hospital and Research Center. He's an expert on hearts. Dr. Parekh, thank you so much for giving me your time. It's a pleasure. I know that you had to dart across the city and you had emergency surgery today, but I'm really happy that you're here.
Thank you so much for the invitation, and I'm looking forward to this conversation.
So I'm going to start at the beginning, the basics, right? Because I don't think we talk about the basics enough. What is a heart attack? What happens inside our body when we have a heart attack?
A heart is a pump, essentially a pump, which takes blood from one part of the body and gives to the other part of the body. It takes impure blood, gives it to the lungs to clean it and oxygenate it, and sends it to the entire body. Now this is a pump. Pump is made up of muscles.
Yes.
Now heart gives blood to the entire body, but heart also needs blood for the muscles to function, to pump. Okay, so there are very, very tiny 2 or 3 millimeter tiny arteries which run on the surface of the heart. Okay, the 3 major arteries. One runs on the front, one on the side, and one on the back. These 3 arteries give blood to the heart. Okay, they are the nutrition to the heart. Now these arteries are prone to develop blockages. Okay, one of these arteries, especially the major one, there are 3 major arteries and there are branches. Any of these major arteries develops slow or sluggish or complete cut of blood supply. The heart muscle that is being supplied by that particular artery starts getting necrosed. Necrosed means dead. Now, when these blockages happen over a period of time, 40% blockage, 50% narrowing, 60%, 70%, 80%, 90%, people get warning signs. But sometimes they happen very suddenly, like from 50% to 100% in fraction of a second. And these are the times when a person gets heart attack. When person gets a heart attack, they typically feel discomfort in the chest.
So that means that portion of the heart is not working anymore. That's what a heart attack is.
The first thing that happens is heart muscle starts getting less blood supply, and that's why the whole muscle will not contract. A part of heart will stop contracting. Other parts will still contract. Okay, that is one. And second, because of the lack of blood supply, there are pain fibers on those heart muscles that get activated, and they send pain signals to the brain, and that's why you get pain, just pain, or whatever you call as Hollywood heart attack, like pain.
So that's the heart telling us that something is wrong. Otherwise, you'd never know.
It's a crying of the heart muscle. Yeah. This is the physiology behind heart attack. Okay. This can have various presentations.
Yes.
And various consequences.
Okay.
Two are completely different now.
Okay.
When you talk about this particular heart attack, the presentations are right from burning or acidity to sudden cardiac death. It can vary from a very, very mild, just burning in the chest, to very massive heart attack, which causes a person to drop dead. So it can be varied presentation.
You said burning like acidity. So now my next question is going to be, how do I know this is not just acidity or I'm having a heart attack?
It's a very important, very pertinent question. Acidity is typically something that happens either while you're very hungry or immediately after a heavy meal. It's a burning kind of a sensation in the middle of the chest or even in the stomach.
Yes.
Somebody who's more than 40-45 years of age, who's never had acidity issue before, because we know there are people who have acidity, who they tell you that I get gastritis or acidity quite often. I have to take Pantocid or I have to take Eno for that. But somebody who's never had acidity before, is a male gender, who's above 40-45 years of age, and suddenly out of nowhere tells you, I'm getting burning or acidity, beware. Number two, when I walk, I get burning or acidity.
Yeah.
But if I sit down, it gets better. That is pain from heart, not acidity.
If there is, and I'll come to why you said male in a minute, but if there is someone who is above 40 who does get acidity on a regular basis for whatever reason, is it possible that after 20 rounds of acidity, 21 might actually be the heart?
Yes, it is possible, and it is quite...
How to rule that out?
Yeah. So, the only way to rule that out is one, whether the symptoms are exertional or no.
Okay.
And two, get an ECG done in a nearby hospital. Rarely, very rarely, a normal ECG will have a heart attack. If the ECG is normal, you have time.
How often should we get our hearts checked?
I would say not heart. I would say your health checked.
Okay.
Because heart attacks or heart issues come up because of various things, like high blood pressure, diabetes, high cholesterol. That's why regular checkups are extremely important. They will tell you what is your current risk profile.
Right.
Out of, let's say, there are 10 things which lead to a heart attack, how many of them you already have?
What are the early signs of, other than the fact that, okay, if you test to have high blood pressure or diabetes or cholesterol, what are the early signs that we can pick out that, hey, there's something wrong with my heart, I should go get this checked out?
Yeah.
So if you have acidity, go get it checked out, right?
Yeah.
Yes. That's after that?
So, okay. Any pain, any discomfort in any area from neck to navel and back that comes on activity or exertion and settles on the rest, please look at your heart.
Okay.
Heart pain is not typical Hollywood heart attack that you will get pain on the left side. Heart is not on the left, it is on the center.
Yes.
So you'll get a pain on the left side and sudden squeezing. No, it can be that, but most often it is not that. Okay. So heart pain can be very, very vague. As I said, burning, then heaviness in the chest, not pain, heaviness. As if somebody has put a heavy stone on your chest and it gets relieved when you sit or rest. It can often come after 1 or 2 hours after a heavy meal and relieved after some time. Pain in the jaw, very typical. Pain on the jaws, which comes on exertion.
Okay.
We directly tell them, please go and look at your heart. Very, very classical and never stressed upon so much. Pain at the angle of the jaws. Pain in both the shoulder blades.
Okay.
Pain radiating from front to back. pain radiating to from front of the chest, throat, and abdomen. These are all symptoms of heart pain or pain because of blockages. Okay, so this is when we say, and especially all this coming on activity or exertion and settling or reducing or subsiding when you sit or rest. This is when we say that please go and look at your heart. So these are some early signs of a blockage.
So you talked about a heart attack that's caused by blockage, right? Which is when the muscle itself is not getting fed, and so then it starts to die. But there are other parts. There's the valves, there's the blood that's flowing in and through the heart. There's the rhythm of the heart. All of those things. Will those present with different, symptoms? Are there early signs that there's some things that might be wrong with the heart? Sometimes people are born with defects that only pop up later in life.
Correct.
How do we know?
Absolutely. So if I talk about heart diseases per se, two broad categories. One, congenital, that means born with, and two, acquired, that means you develop them because of your habits or because of your genes later in life.
Yes.
Okay. Now, we spoke about the heart attack because of the blockage. Sometimes there can be heart muscle problem, which is called cardiomyopathy.
Yes.
Cardio means heart, myo means muscle, and anything that is abnormal means pathy. So cardiomyopathy. Cardiomyopathies are nothing but either too thick muscle or very thin and loose muscle, which is not able to pump blood effectively to the requirement of the body, as per the requirement of the body. This will have different symptoms, and these symptoms are called heart failure symptoms. Cardiomyopathies lead to heart failure. Heart failure and heart attack are two different entities.
Okay.
Heart attack is when there is a blockage and heart muscle starts dying. Heart failure is when the heart is not able to pump out adequate amount of blood to the entire circulation. It gives two types of problems. One, because all the organs don't receive adequate blood, so symptoms of undersupply. And two, heart is going to receive the blood from the impure blood from the other side. So that kind of it is a traffic jam. Yeah. On one hand, heart is receiving blood, but on the other hand, it is not able to pump it out. So lungs get congested with blood and water. So the symptoms are breathlessness, swelling in the legs, swelling in the abdomen, undue tiredness, undue fatigue, which is gradually progressive. It doesn't happen like a heart attack on one day. Starts very, very slowly and becomes more and more severe as the time goes by. So these are signs of heart failure, which is basically a result of cardiomyopathy, weakening of the muscle of the heart, which could be because of, without any blockage, just the weakness of the heart muscle. Then there could be problem with heart rhythm.
Yes.
What is rhythm? When you say rhythm is heart beats as per the body's requirement. If you are sleeping, heart will beat at the rate of 60 or 55 because all the organs are resting and the requirement of the body is not too much. If you're fighting with somebody, if you're angry, if you're exercising, heart will beat at the rate of 120 beats per minute because you go in that fight or flight or fright response and body is ready for any action. So as per the requirement of the body, heart beats slow or fast. So some person who has either very slow or very fast heartbeat doesn't receive blood in the brain, suddenly just collapses in front of you. So this is called syncope or blackout. This is a classic symptom of heart rhythm disturbance. And then comes the valves. Heart has 4 valves. These valves, either by birth or because of advancing age and wear and tear, become problematic. Valves are basically tissues of the heart which maintain blood flow in one direction. Blood comes in the right upper chamber, then goes to right lower chamber, then goes to lungs. But right lower chamber blood cannot come to right upper chamber because there is a valve in between. Okay, so when the blood from right upper chamber wants to go to right lower chamber, the valve has to open. Then when blood goes there, it closes, and then blood goes further in the lungs. So it's like a one-way signal. You can only go in one direction, cannot come in the other direction. But sometimes this valve either develop narrowing, that means it doesn't open fully. So traffic jam on the chamber which is feeding.
Yes.
It is trying to get the blood across, but valve is not opening only.
Okay.
And the lower chamber will not receive adequate blood. Or sometimes they start leaking. That means they do not close, but they do not close properly.
Yeah.
It's like a door which is not shutting down properly. So your air condition effect will keep going out. So the blood will keep leaking into the reverse direction where it is not supposed to. These again can have completely different symptoms. Symptoms of tiredness, symptoms of chest discomfort, depending on which side valve, right side or left side valve is involved. With the right side valve, you can have abdominal swelling, leg swelling, fatigue. Fatigue means tiredness.
Yes.
Or if there is a left side heart valve involved, you can have blackout, you can have sudden night breathlessness. You're sleeping comfortably and in the middle of the night, 2 o'clock, you'll feel like you're flooding, you're drowning in your own secretion. You'll get up.
All of the things that you talked about, assuming we reach a hospital in time, are all these things treatable now?
Okay, I'll modify it. If you pick up in time, all of them are treatable. Number one, non-communicable death problem is because of heart issues. Cardiovascular disease, CVD, is the number one killer across the world.
Yes.
Okay? Including our country. 85% of these deaths are preventable. If you do primordial prevention, that means change the risk factor before they start coming up. And 2, early diagnosis and treatment. So if you do these 2 things, risk factor modification and early diagnosis and treatment, 85% of heart-related deaths are preventable. And that is so many deaths.
I do want to ask you, you did talk about the fact that cardiovascular disease is the number one killer in India, at least. Is it because genetically we are prone to have bad hearts? Or is it our lifestyle as Indians and the food we eat and the lifestyle that we maintain that, so are we born with this, genetically predisposed to this problem in our race? Or is it both? Why are we having this problem?
I want to answer this question in 3 parts.
Okay.
1, genetics. 2, our other risk factors. And 3, our lifestyle. Okay. Now genetics. Indians are predisposed to developing more severe and early heart disease.
Okay.
Okay. And that is genetics.
That's just genetics. It's just a race.
Just how we are born with.
So if our parents had heart attacks at certain ages, we are at risk.
Oh, certainly. If your parents or siblings had a heart issue, you are at a definitely higher risk. Twice more likely than any other individual of that particular age. So now that is genes. Second is our other risk factors. India is diabetes capital of the world.
Yes.
And diabetes is, if one person has diabetes, another person does not have a diabetes. Rest all is exactly same. 40 years of age, same weight, same exercise routine. Just because the other person has diabetes, he is twice more likely to develop heart attack compared to the person who does not have diabetes. And we have the highest number of living diabetics in the world. That predisposes our risk of getting heart attacks. So we are diabetes capital of the world. So that is our other risk factor, what I'm talking about. And third is our lifestyle. We are not so tuned to physical activity.
Yes.
That is the biggest problem. Our diet, yes, it's sometimes bad, sometimes not bad, sometimes good. But we are not, one thing is there, we are not tuned to. If you go to the Western world, every person, at least out of 10, at least 6 or 7 people will be doing some sort of exercise.
And playing sports.
And sports, exercise. It's inculcated in their lifestyle. We don't do that. Our physical activity, exercise, sports, involvement is very, very low. Now, that directly leads to heart not being tuned to exercise, overweight, diabetes, high blood pressure. All these problems come in when you have lack of exercise.
We're also part of the world right now that's discussing 90-hour work weeks, right? And we've had various conversations about, is it now a generational gap between people who are in their 60s who believe that that is the only way to be successful, and the younger people now saying that's not tenable. We can't live like that. And there are conversations about if you want to be successful, if you want our country to do well, this is how you have to work. What happens to our hearts when we work 90-hour weeks, 100-hour weeks?
So two things which, I mean, I wouldn't say there is any correlation between work, how many hours you worked versus a heart attack. But there is correlation between lack of physical activity
yes,
and heart attacks. Lack of socializing and heart attacks.
Okay.
And lack of sleep and heart attacks.
You said obviously exercise and sleep is important, but you also said socializing. So you don't mean ki go out and party, and you actually mean even spend time at home. So going home and staring at your wife on Sundays,
I
you're
know.
saying.
I know. So there's a lot of debate on staring at your wife, yeah? Yeah.
Are you fundamentally sexist? But I think that, so what you're saying is spending time with family and, sitting down with your spouse is actually good for your health.
With your spouse, with your kids, with your friends. It's good for your mental health. It releases the happy hormones. It de-stresses you. There is a recent Harvard study which has said they compared people who lived 70 years, 80 years, 90 years, and they went back 30, 40 years. They found out that those who lived alone, lived and versus those who lived with families or with friends. So those who socialized more lived longer compared to those who did not socialize.
Do men and women, you said, of course, if you're above 40 and you're male, then these symptoms. Is cardiovascular disease a male problem, or do women just simply not pay enough attention? What is going on there? What's the difference there?
It's not a male problem for sure.
Okay.
Yes, males are definitely more predisposed. When you talk about risk for heart attack, when you say race, Indian, sex, male, it comes there. Okay? Male sex is a risk factor compared to female sex when you're talking about heart issues. But till 5 to 10 years after until 5 to 10 years after menopause. So females, before menopause and up to, let's say, 5 years, 7 years after menopause, because of their estrogens, are protected from getting blockage-related heart issues, not from other heart issues. Blockage-related heart issues, that means heart attacks. Mind you, if a female who's not reached their menopause yet, but has diabetes, that protection of estrogen is gone.
Okay.
She's equally predisposed to get a heart attack as the male sex of the same age. So, yes, females do get heart issues little later in their life, but beyond age of 50, 55, the incidence of heart attacks or heart blockage related issues are exactly same in males and females.
What is a silent heart attack?
Okay. A good question. I mean, so if there's a candle here, and I'll say, if I close your eyes, and then I'll put your finger in the candle and flame, because you're not seeing it, will you not feel it? You will feel it. You will take your fingers away, right?
Yeah.
Just because your eyes are closed doesn't mean you don't know what is happening there. Because there are pain sensors on my fingers, which take the sensation, that obnoxious pain stimulus to your brain, and the brain signals your hand muscles to move away.
Yeah.
That happens in fraction of seconds. So now heart muscles, when they stop receiving blood supply, they start crying, and that cry is pain, which is carried by nerves, which take stimulus to the brain, and you know that, okay, something is going wrong. Pain. But in diabetics, because of high circulating sugars, these small nerves which carry this pain sensation are damaged. So they do not feel the pain at all. And they present later with complications of heart attack. A patient has just walked in for a health checkup, and we do a 2D echo and we say, oh, you had a heart attack at least a couple of months or years back. And the patient will say,
has no idea.
I never had anything like that. I have no idea.
And I've heard that this is possible for smokers as well. That smoking could lead to silent heart attacks.
I don't think that's true. I mean, smoking does lead to double or triple the risk of heart attacks compared to non-smokers. But not so much. But yes, I mean, if you combine diabetes and smoking, the risk is 5 times more. So yes.
There's also the idea of vaping now.
Yeah.
So, I mean, we know every piece of research tells us that no good can come from smoking. Smoking is bad for you. However you read that paper, vaping?
It is. So I'll tell you, any type of smoke inhalation or vape inhalation that you do ultimately causes blood viscosity to go up, thickness to go up. Blood viscosity goes up, the thickness of the blood increases, the circulation in this small, and we're talking about arteries which are 2 millimeter, 3 millimeter, or 1.5 millimeter in diameter. 1.5 millimeter is this. So thicker the blood, less the circulation. And if you already have pre-existing 50, 60, 70% narrowing in an artery which is originally 3 millimeter only, and there's 70% blocked then. So thicker the blood, more viscous the blood, less the blood supply, and more the chances of clot formation and heart attacks. So no type of smoking or vaping is not good for heart. Definitely no.
What about alcohol? There was a time when they would say, 1 glass of red wine per day is fine, or these many drinks in a week is fine. Now we're reading that 0. Nothing is fine. So where do you stand on alcohol?
So no alcohol is good for heart, at least scientifically, yet. Okay. There was a study long back which was done in European population which studied red wine drinkers versus non-red wine drinkers. And they found that red wine drinkers lived longer or something. And then they said that a glass of red wine is good for heart. That's what they concluded. But that study had a lot of fundamental fallacies. It has been rejected multiple times.
But it's a catchy idea that everybody loves.
I know. I mean, a lot of patients ask me, Doc, wine is good, right? No, it's not good. What is not good is binge drinking.
Okay.
There's something called as holiday heart syndrome. When you binge drink on weekends, on the next day morning, you get more admissions in the emergency room with heartbeat becoming irregular. Because alcohol causes heartbeat to become sudden, fast, and irregular. So this entity is called holiday heart syndrome. It is there in textbooks. Okay. And that is directly related to alcohol and binge drink.
So I'll give you a tough question. Okay. A glass of red wine or a glass of Coca-Cola?
If you're having a Coke Zero, no calories, no sugars, you may be okay. But yes, it has artificial sweetness, it has color.
Yes.
So, which in long term may or may not be good. But these are areas where you don't know. Okay. These are gray areas. We know there is no benefit of one over the other. I mean, for your leisure in small quantities, you can have either. It's fine. But anything not in moderation, anything in excess is definitely not good. That much, I think it's clear.
Yeah. So that brings me actually to talk about sugar, which they say now is the poison of our generation, right? Yeah. Because, and I remember there used to be a time when people would say heart disease was caused by cholesterol, and so the eggs and the red meat, and they would tell you to avoid things like that. There's a sort of change in focus now to sugar, saying processed sugar, processed food, just consuming sugar, your drinks and all of these sugary items that are now so easily available. That is the real culprit. In your opinion, which is it?
Both.
Both.
Yes. You can't say red meat or high fat diet is not responsible for heart attacks. As of now, yes, many people say cholesterol is a myth and etc. etc. As of now, there is no scientific data to say that no, cholesterol is good for heart or not good for heart. No. So yes, high fat diet is associated with increased incidence of heart disease. But along with that, high carbohydrate diet, where the sugar comes in, is also associated with increased incidence of heart issues. Why? Because yes, brain functions on sugar. Okay. But sugar essentially is needed for a very in moderate quantity. Anything more, and it's gonna get deposited here and there. It will cause weight gain. It will cause fatty liver. It will put your diabetes off the chart if you have diabetes. And directly and indirectly, both ways will lead to heart issues. So I wouldn't say that only sugar is the culprit, fat is not the culprit. Low fat, low carbohydrate diet is what we advise our heart patients to follow.
Is high cholesterol caused specifically by fatty diet, by consuming fats, or by consuming sugar and carbohydrates?
Both. It is caused by fat as well as carbohydrate, both. And that's why excess amount of carbohydrate is bad.
Okay.
So it is caused by both.
How important is it to maintain weight?
Very important question. Amazing, but very common sense question again.
Yeah.
Ideal body weight is one thing which will prevent not only heart disease, but a lot of other factors which lead to heart disease, directly and indirectly. Now, if you have high body weight, what are the problems that can come with high body weight? Hypertension affects heart. Diabetes affects heart. Obstructive sleep apnea or OSA affects heart. You can't move, lack of exercise, lack of physical activity affects heart. All this can be prevented by maintaining an ideal body weight. So, yes, dyslipidemia or hypercholesterolemia again comes with obesity, affects heart.
There are now drugs that will help you lose more weight, like an Ozempic or a Manger or the...
Manger or Ozempic.
So, and here's a question, right? So, it's possible to take these drugs and come out of the risk zone of being obese and being overweight. And so the drug then puts you in a safe zone. But does the drug have side effects on the longer term that will put you in the risk zone for other things? So is that a toss-up? And how do you, for example, as a practicing doctor, decide this is a case for weight loss drug and this is not a case for weight loss drug?
So any treatment that is considered or offered, we always see risk versus benefit ratio. Okay. The solution cannot be bigger than the problem.
Okay.
And I would put bariatric surgeries or the weight loss surgeries and drugs, the chemical weight loss, Manger or the Ozempic, in the same bracket and discuss them about the whether or not and to whom, for whom. Now, yes, there are patients who have high incidence family history of heart disease, bad cholesterol, diabetes, which is not able to control with insulin also not coming down. You would consider that, okay, to hit the ground running, as we call it, or to get onto that outer safer zone, you can consider these drugs, although we don't know the long-term side effects because these are newer molecules, or you can consider the bariatric surgery option, like stomach stapling or whatever they call it. Again, they will have their own set of complications. But when you know the risk of complications is far, less than the risk of this person getting a heart issue,
yes,
then you offer it to the patient. But it is always better to offer or take or do these things in a motivated individual. That means somebody who's already working very good, very actively, very aggressively on their diet part, on their exercise part. And then when it fails, you go to this surgical or chemical way of losing weight. Because if you don't do the first two things and directly go to this, I wouldn't say easy option, because neither surgery is easy nor the drugs are easy. They will have some stomach issues and etc. But if you directly go to these options, you can't do them for life. And once you stop them, you will again gain weight. So what have you achieved? Nothing. So that's why these things are scientifically proven. These things are safe. There are some long-term side effects or long-term effects, I would say, that need to be seen in a couple of drugs. But in a given patient, if the risk of diabetes, bad cholesterol, obstructive sleep apnea, high blood pressure is so high, we call this metabolic syndrome. A combination of all this put together is called metabolic syndrome. The risk of metabolic syndrome and its complication is very high. You do offer them these surgeries or the procedures or the medication. But yes, they are not a long-term solution. And that's why you need to have a long-term plan.
Do we know for clear now what the long-term side effects are, possibilities for these drugs?
Not yet, honestly.
Because we've just started using
Yeah. I mean, number one, they are not very old. And number two, they are not being taken in large group of patients.
They are now.
No. I mean, large group means when you talk about statins,
Right.
the ones which reduce cholesterol,
Hmm.
millions take it.
Right.
And then, okay, out of 1,000 patients, 10 people develop leg cramps.
Yes.
But only if 100 had taken it, only one would have developed leg cramp, which is too small a number to consider this as a side effect. You understand what I'm saying?
Yes.
So, to understand minute side effects or adverse effect, I would say, or non-desirable effects, if you put it in the right way, you have to have the delta, the denominator in a very large group, which is not yet, in my opinion.
So anyone taking weight loss drugs like Ozempic needs to know at this point that we could discover serious long-term effects over a period of time that we don't know of as of now.
That's true for every drug, not only Ozempic. Every drug which is not there for long, which has not been there for long, and which is not a very, very popular, commonly used drug. Okay? See, you have to understand. There are drugs where there is no choice. You know the complication, that this will have this issue. But you have to take it. There's no option. And there are drugs which you can choose to take, choose not to take. When you decide to take a drug which you can choose to take, choose not to take, you have to understand that there could be non-desirable effects in mid-term or long-term, which we are not yet aware.
When we talk about side effects of medication, automatically the reaction from someone listening will be like, I will just only take Ayurvedic because it's natural, or I will only take homeopathic because it's so mild. What's your reaction to that? What's your response to that?
Any medication where you don't know the content or composition, what it contains, because even plant-based sources, medications can have side effects.
Yes.
Like malaria drug, the allopathic malaria drug is derived from a plant, but it can have side effect. Okay, like the chloroquine comes from a plant. Okay, so it's not chemical versus plant. Anything where you don't know the content, I would not be comfortable taking it because I don't know how it acts on the other systems, what side effects to expect, and how it will interact with other drugs that I may or may not be having.
Is there evidence now that microplastics from single-use plastic bottles and things like that are making our hearts weaker?
Yes, microplastics can not only cause cancers, but they can make our heart weaker. They are definitely dangerous. And but again, it's an evolving area. The full effect or the potential of adverse effects still to be understood and known. But yes, it has been noticed and it has come to light that microplastics do affect heart. They make heart muscle weaker. And because otherwise earlier all the focus was only on cancer potential of the microplastics.
We haven't spoken about exercise yet. We did talk about managing our weight and managing food intake. Again, there are those people who say, oh, you have to go to the gym every day, you have to lift the weights, you have to train hard. And then there are the anecdotal stories about so-and-so was in the gym and he had a heart attack. So what exercise do you recommend?
Any exercise. So basically any cardio or aerobic exercise which pushes the heart rate up and brings it to a level which is advisable for your age. And how do you derive that number? It's very simple formula. 220 is the number. 220 minus your age. So let's say if I am 50-year-old, 220 minus 50 is 170.
Yes.
Okay. Now 80 to 90% of 170. That means 150, 145 to 150 range is my target heart rate.
Okay.
Okay, 220 minus your age and 80 to 90% of that particular number is your target heart rate.
Okay.
That's the heart rate, or that's the zone where you want your heart rate to be while you're exercising. Now, these exercises or cardio or aerobic exercises are many. Brisk walk, jogging, cycling, stationary cycle or cycling, uh, aerobic, Zumba dancing, swimming, all these are, or running, all these are aerobic or cardio exercises. But the most important question here is how much. So for a healthy heart, if you are not overweight, if your ideal body weight, 150 minutes of cardio every week, that means 30 minutes of cardio 5 days a week is what is recommended.
Okay.
If you are overweight, your exercise should be more because you want to not only keep the heart healthy, but you want to lose some weight.
Yeah. If we see someone around us showing symptoms like you described of having heart issues or someone's having a heart attack, as a bystander, what should we do?
So there are two types of situations you're likely to face. One, who's a person who's just complaining of chest pain or whatever I spoke about. Chest pain, epigastric pain, burning, crushing pain. And second, a person who's
just collapsed. Yes.
Two are two different.
Okay.
Approach to both is totally different. Approach to the first individual is not a cough or a squeezing manner. There are so many videos that you see start coughing or vigorously or go to that baby child position. No. Approach to the first patient is call for help. Go to the nearest hospital. And there is another person who's just collapsed. Now we don't know whether he had a heart attack or heart rhythm related disturbance, which is not a blockage. Just the heart rate which became too fast or too slow.
Yes.
Yeah, and had a blackout. Or something even more dangerous like a rupture of one of the biggest blood vessel of the body, aorta, because aortic dissection or something like that. In these patients, the first thing to do is maintain circulation. How do you do that? Put the person on a flat ground with two hand CPR basically till you get help.
Yes.
Because the brain will die in few minutes. A heart maybe you may be able to revive heart after 20 minutes. But by the time brain is dead. So the patient lands up in a coma. Awake, alive patient, but brain dead. So it is important to maintain perfusion. And brain is the most labile to lack of blood supply.
Yes.
So first thing, put them on a flat surface, start doing CPR. On YouTube, Google BLS, Basic Life Support. Very good videos. These are for bystanders. These are for common population, not for medical people.
Yeah.
And get yourself accustomed to or tuned to, BLS.
There are a lot of changes right now in treatment. What, according to you, and this is less on the advice, and I'm more excited to know, what innovations are happening in your space. What, according to you, is the most exciting innovation you've encountered in the last few years that you're most excited about?
So I would say there's a conflict of interest there.
Your innovation is the most exciting.
Yes. What I do is something that excites me the most. Okay. But I think it's the... so in earlier days, if you have had a heart valve problem, a heart valve, which essentially carries blood from one chamber to another and allows it to flow only in one particular direction at the right time and then stops coming it in the reverse direction. It stops from coming it from in the reverse direction. When they become problematic, either too narrow or too leaky, in earlier days, you had to do an open heart surgery. That means you undergo general anesthesia, cut open the chest by actually sawing the breastbone, heart and the entire circulation put on an artificial pump. Heart is not brought out, but heart is opened. The defective valve is brought out, or rather sutured or repaired inside. If it is not repairable, it is cut out and new valve is sutured in. And then you sew the heart back, sew the bone back with wires. And then you can put the circulation back onto the heart, and then patient remains on the ventilator for 24 to 36 hours, ICU for 4 days, hospitalization for at least 6 to 7 days, and the full recovery to normal functioning takes 4 weeks, 3 to 4 weeks, because the bone takes that much time to heal. It's like a fracture that you created.
Yes.
Now the same thing can be done with a small needle stick in the groin in less than an hour on a beating heart in a patient who's alive and talking to you, awake and talking to you, conscious patient. Patient walks the same day evening, goes out of the hospital the next day, and there is not a single stitch on the body. There is no downtime. So this is called transcatheter valve repair or replacement. It is done for various valves, aortic valve, mitral valve, and there are other valves, pulmonary valve. So these are the procedures that excite me the most. And I would say that is the most groundbreaking innovation in my field, that is the interventional cardiology and then subspecialty of interventions.
We're talking a lot about using AI now.
Yeah.
In your space specifically, in cardiac surgery or cardiac health, where is AI playing a role and how do you expect that to increase going forward? Are you using it right now? What's going on?
We're not using it so much because AI is basically machine learning based on data.
Yes.
And based on patterns, recognition of patterns, and finding out a correlation between patterns. Okay. Now, there's a lot of research going on in cardiology and AI. Okay. So, a lot of our cardiac CT scans, cardiac images that we acquire on 2D echo or cardiac ECGs that we take. One is acquisition of the images. ECG nikala.
Yes.
ECG taken out by a paramedical person.
Yes.
Or heart sonography done by a paramedical person. And the interpretation of ECG or interpretation of those images done by a doctor or cardiologist. Okay. Now that may not be available everywhere.
Yes.
Okay. There are only as many cardiologists. This data, based on the patterns and recognition of patterns, in future is going to be analyzed by AI. And that will give a red flag or a green flag and divide patients into low risk, intermediate risk.
Triage will happen.
Triage. Yeah. Low risk, intermediate risk, high risk. This is just one example. A lot of
there's this great project happening in India right now, and I think it's a combination of Government of India and Google and a couple of other, where basically they're using AI to be able to triage and detect TB, tuberculosis, by the sound of the cough. Because up till now, in order to detect tuberculosis, you have to do an X-ray. But just by the sound of the cough to be able to tell the difference between this is just a cough and this is tuberculosis. And then from there, you've already divided through the population and then you can push it forward.
Yeah, so
it reduces the number of people presenting at your primary healthcare center.
It makes your denominator smaller.
Yes.
It screens for you.
Yes. It would have been very useful in COVID.
Yeah. I mean, so like those thermal scanners at the airport.
Yes. Yeah.
Right? 100 people walking, you'll know, okay, this guy is glowing.
Yeah.
On the thermal scanner. So, yeah, okay, this guy may be having fever. So, this is like mass screening.
Yes. And especially in a country like India where sheer numbers of what we're talking about.
We are overwhelmed so many times.
And we still, still the number of our paramedics and our doctors and the people who are able to do scans doesn't match the kind of people who need these services.
Absolutely. There is still a deficiency of doctors in India. So, despite having in such big numbers.
Why do we still have an deficiency of doctors in India? Why, are we not able to meet those numbers yet?
So, it's a...
we have enough young people who want to be doctors.
Honestly, there are two things. One are population. Numbers very big.
Yes.
Two, it's a relative deficiency also. Like there are parts of urban India where there are doctors which are more than required. And the part of rural or suburban India where there are doctors which are not there only. Now, that divide is sometimes really wide. Okay. And health infrastructure, remuneration, facilities for the families, all these things are sometimes a constraint when a doctor decides about settling in a metro versus a small town. So, yes, we have a deficiency, sometimes a relative deficiency, like more than required in one particular part and none in another particular part. But there's the area we need to really focus and work upon.
Do you expect going forward that India's health needs will be met by the private sector? or by improved services in the public sector? So better government hospitals or private sector hospitals all over the country?
I would say medical insurance for everybody would do the trick. Because our population cannot be managed by government hospitals. Okay. And it is, I mean, to be fair, we are a country where our needs are so many. We have people dying with road traffic accidents by falling off train. We have people dying of TB, which has been eradicated in most parts of the world. We have people dying from malaria. We have infant mortality. So our needs are so many that only government cannot do this. And again, where public-private partnership will come in.
Are we doing enough R&D in India in the medical space for your liking? I know that you work in a hospital that also supports a research center.
Yes.
But across the country, we have tremendous capacity. We have the intellect. Do we have the research centers?
So we do have research centers like the Virology Institute in Pune, which became famous during COVID.
During COVID, yeah.
Or Hafkin Institute, which is a vaccine mega hub in Bombay. We do have such centers. Now, the problem is there is treatment of the problem, there is prevention of the problem, and then there's research. A young country like ours sometimes gets overwhelmed with treatment and then barely manages to reach prevention. So research becomes sometimes a neglected field. But having said that, we do have a lot of research projects that happen across the country in various government and non-government hospitals and medical institutions. A lot of good medical research is published. And research is not only a patented thing or there are a lot of Indian doctors who have patented a technique to perform a surgery, which is a part of textbook in every part of the world. They have taught the world that how to do this particular surgery by sheer number or sheer experience that we have.
Yes.
So that is also research. So research is not something that you get published in Harvard or you get a front page in New York Street, whatever like that newspaper is. Research is everything. A doctor who does a procedure which otherwise would be done differently. A doctor who devises an instrument which is otherwise never thought about is a research. And we have a lot of such experts, doctors, researchers. They have given contributions in various fields.
In your career, what is the most memorable success story that you've faced on a case or a particular incident that you were handling?
There are many.
Yes.
One patient who's a known heart patient undergoes has undergone an angioplasty with stents, whatever, in the past. Now has a bladder problem and needs surgery for that. Now that patient undergoes that bladder surgery in our hospital. And immediately after the surgery, when the patient is brought back to the ICU, you see the patient is suddenly pulseless, collapsed.
Okay.
BP is not recordable and patient is arrested. There is no heartbeat. The team of doctors in the ICU and the nurses, they start the CPR immediately. Within 7 to 8 minutes, they realize that this is not a problem that can be solved just by CPR. There's something undergoing there. He may have developed a sudden acute blockage in the heart. And that's why the heart is not getting blood supply. And that's why heart is not picking up despite CPR. What to do? You have to transfer this patient to the angiography suite, or where we do our angiographies and angioplasties, we call it cath lab.
Yes.
But you can't do this while doing CPR. And the moment you stop CPR,
the person will die.
The brain becomes vegetative. So, what to do? In such a situation, and this is a prime example of team where the team pitches in. the team of ICU doctors, the administrators, everybody says, okay, let's put him on extracorporeal circulation. That means put two big pipes while CPR ongoing, and that's called ECPR, ECMO CPR. ECMO is extracorporeal membrane oxygenator, which is a artificial pump which takes the function of heart and lung. Okay, immediately that is ECMO is put in a patient who's undergoing CPR in less than 12 minutes, and the patient on ECMO transferred to cath lab undergoes successful angioplasty. There was one blockage which was removed by me and my team, and this patient undergoes removal or decannulation or de-escalation of ECMO in the next 48 hours, goes home in 7 days, and comes back after I'm busy in my OPD, and comes back suddenly, and he was quite weak when he went home. Suddenly after 3 months he comes back, like I couldn't recognize him. So these are the patients where you feel the technology, knowledge, infrastructure, team dedication have all combined and improved life of an individual.
So, have you ever lost a patient?
We have all lost patients.
How do you come back? How do you mentally come back from that moment?
That takes a toll. Because some patients and families will accept that yes, we tried our best. Some will always want more than what medical science can do. Okay. And for us as medical practitioners, and it's not about losing a patient, it's about even not getting right outcome from the patient. We are just trying, all of us are trying, and we still don't see the patient improving. So this takes our morale down, and that is not something that I think I come back very easily from. So again, as I said, we go to our family, spend time with kids, and you come back next day refreshed, and you are like, okay, let's new day, new hope. This is something sometimes very difficult, especially with a patient in whom you have tried your best for many days, and there were like signs of recovery, and suddenly that patient goes down. Then you feel very sick, very bad. Yeah.
Do you do enough, or what do you do to maintain your mental health equilibrium? Outside of the hours that you're already spending in the OT and,
So I try to take some time off intermittently, go on small holidays. I read sometimes, I read books.
Not medical books.
Not medical books, ask me. So, yes, I spend time with my children. I have two beautiful children, so I spend time with them, with my family. And yes, I watch Netflix. So these are the things that I do. Maybe 3 to 4 times a week, I try to do some little bit of exercise.
Because, doctors will tell us work-life balance, and you have to exercise, you have to find time to eat right, you have to, relax and de-stress. And how much time do you have to do all of these things? What are your work hours like?
Not mine. Almost every doctor works like, I start my day at 8 o'clock in the morning. I'm in the hospital by 8:15. And I leave typically by 8:30, 9 in the night from the hospital. So these are my hospital hours. And that is Monday to Friday. Saturday, I start at 8, but I try to go back home by 5 or 6. And Sundays, maybe I spend only 2 or 3 hours in the hospital, not more.
You go in on Sundays?
Every Sunday.
Okay.
Because there are patients which are admitted under my care, and it's like for every doctor, I'm not doing something very heroic or something very different. There are patients who are admitted under our care, which are sometimes very sick. Some patients need counseling, some patients need advice, some patients need continuous monitoring. So these things sometimes are only done when you go there, when you see the patient physically, personally, pay attention to the details. So we call it our rounds. So all of us, I think, go for our Sunday rounds. So for all the admitted patients, so that is maybe 1-2 hours a day on Sunday morning.
And do you have to keep explaining to your family why?
Yes, my daughter tells me, hey, today is Sunday, today we'll go to hospital only for 2 hours. She never say, because she knows Sunday means only 2 hours. It's not a holiday.
Yeah.
Yeah. Yes, there is, but I think I grew up in a medical family. I grew up seeing this, and I think my kids also have grown up seeing this. And my wife is a doctor, so we understand each other.
You know, there is a massive difference between the doctor-patient relationship, especially in the private sector in India, and the way it is overseas. Where in India, we expect a certain level of responsiveness from our doctors, right? So people will WhatsApp in the middle of the night, or they will call you at any odd hour. They will expect you to know the history of the case off the top of your head. Doctor, I'm calling from so-and-so. Remember, you treated my mother 6 months ago, right? And that is a kind of liberty that is not available overseas. It's only in India, and it's also because our doctors respond to us in that manner. I want to ask you this. For everybody, what communication and, responsive etiquette do you think we should keep in mind when we are reaching out to our doctors? Across the board, pediatricians, cardiologists, gynecologists, everybody.
So, yes, sometimes such type of communication is bothering to us because it's only peculiar to our country and not to the Western world. But at the same time, the respect that we get in India is not there in other part of the world for doctors, because we do the extra thing. We go an extra mile by responding in the night or by being available on a Sunday or a Saturday. So it's sometimes it's a nuisance, sometimes it's a responsibility, sometimes it's a need of the hour, and for every case it may be different. There are times where I end up saying, "Why did you not call me if this was the problem?" Okay, so, or why did you not reach out?
Yeah.
Many a times to my sick patients, I end up saying, I don't mind false alarm, but don't not raise the alarm, because there may be something going on and the patient may be too late to inform. So, for such situation, what I would recommend is, unless it's a problem which has happened very acutely, very suddenly, and unbearable, I would refrain from informing or calling my doctor. If it is an acute or serious problem, you must inform the doctor, but you must go to the hospital first, to the emergency department. I cannot differentiate on a phone or a message a minor problem from a serious problem. So a patient needs to visit the hospital urgently. Do not waste time if the doctor is not reachable, or the doctor, because that's a very basic thing to do. And I think that's what I would say. So I probably don't mind getting messages or calls from my patient. If it is not urgent, when I realize the nature of the communication, I tell them that we will get back to you, or my team person member will get back to you, or you can come and meet me in the OPD or whatever. But sometimes we don't want to miss out on something serious.
Is there a lot of information on the internet right now that's misleading and worrying, and and this happened during COVID. For those of us who were working during COVID in the information space, we had to say, okay, where has this been published? Has it been peer reviewed? Is this a reliable, source of information? But now it's a free for all on WhatsApp and on Instagram. How dangerous is that?
Sometimes it's a very problematic issue, especially when healthcare is concerned. Okay, if you want to talk about which color trouser will go with which color shirt, that's fine. You can take Instagram opinions. But when you're talking about heart health, or for that matter, any other health issue, it's important that if it is fed to you by the social media, see it by all means. Don't believe in it. If you want to do something which is medically important, please talk to your doctor, rather than just believing the WhatsApp or Instagram or Facebook stories that you see. because sometimes it may be detrimental.
Yeah.
Doing and not doing, both. Act of omission versus act of commission, both may be detrimental. So that's why I think reaching out to your doctors, which we just discussed, are very reachable now. It's very important if you want to verify some healthcare related issue rather than just believing the social media, or even do a simple Google search. You'll get a fact check if you are intelligent.
Mm-hmm. Like one of the things that we're discussing anecdotally also is, people who've taken the COVID vaccine are now having heart attacks very young. Is there any sort of study that has been done?
There's no study that has been done because billions of people took vaccines. Okay, so billions of people took vaccines and millions get heart attacks. Even before COVID, cardiovascular death was number one death risk factor.
Yes.
Okay. Now, to attribute one particular death only to vaccine is very, very difficult. I mean, the young people were dying even before COVID. I have done angioplasties or blockages or heart attack treatment in people as young as 25 or 35-year-old, even before COVID. Okay. So, why would you say the same person, if it comes after vaccine, is because of vaccine and not otherwise a predisposed individual or individual who was already at risk of getting a heart attack? So, cause and effect relationship is sometimes very difficult to prove. Yes, we all have seen some anecdotal examples of immediate post-vaccine heart attacks or strokes, but I don't have a data or evidence to prove that yes, this vaccine or this doses causes more heart attack or more strokes compared to the other vaccine or no vaccine. I don't think there's any such data that exists.
If you were to write down a 3-point rule for everyone to look after their hearts well, what would it be?
Know your risk. That means in terms of your family history and genetic predisposition and your current numbers, whether it is blood reports or blood pressure. So know your risk, number one. Number two, eat healthy. And number three, regular exercise. These three things, eat healthy, regular exercise, and knowing your numbers, knowing your risk. If you do these three things properly, you will at least pick up problem in time, if not prevent completely.
Dr. Parekh, thank you so much for spending time with me and answering all of my questions so patiently.
Thank you so much for having me and for this extensive grilling. But good, it was good. Thank you so much.